Hi, good afternoon, everyone. Welcome to APSC 2021, and we now have the Joint ESC APSC Symposium. And this is going to be on data science and digital technologies. It is my pleasure here to also invite to go through the speakers today. We have Mr. Wouter Van Djik from the Netherlands. He'll be talking about data analytics of electronic medical records. Does it help? Professor Barbara Casadei will talk about the Euroheart project, and Dr. Alan Fong will talk about wearable devices in clinical cardiology research. With that, I also would like to invite all our participants to please type your questions in the Q&A. We'll bring it up at the discussion at the end. We will have 3 talks, and there will be a discussion at the end of these 3 talks. And with that, I'd like to invite our first speaker, Mr. Wouter Van Djik from the Julius Center for Health Sciences and Primary Care from the Netherlands. Over to you.
Dear members of the APSC, welcome to this presentation and thank you for having me. I am Wouter Van Djik. I'm a Dutch medical doctor who recently finished his PhD in clinical epidemiology and a learning healthcare system in the Netherlands. Today, I want to talk with you about the data analytics of electronic medical records. Does it help? As a standard prerequisite, my conflicts of interest, and I don't have none to declare. Then, let's start with what if data analytics of EMRs would not help? Wouldn't it be a terrible problem? Research would investigate topics different than encountered in clinical practice and noticed, and then research would also investigate different outcomes than are used in clinical practice. Moreover, care improvement would not depend on what occurs in clinical practice. So basically what you do on a daily basis in clinical practice would have no value for healthcare besides the care for individual patients. Wouldn't that be crazy? For me, I can't believe that. So I'm a real big advocate of data analytics of EMRs. So maybe rename this lecture therefore to data analytics of EMRs. It does help. And to show you that it does help and that there is a lot of value in the data we have in EMRs, I would like you to take you through some research of others and me, where we show that the data, we can do a lot with the data in the EMR, of the EMRs for research. And why is this needed? Well, this is needed because the research costs are rising. Research costs are rising fast. In particular for clinical trials. Here on the left, I've just named some numbers for regular trial in cardiovascular research in the modern Western world today. Sorry, I know it's more for US-based numbers, but those are the ones I have. A cardiovascular clinical outcome trial costs about $160 million US, needs about almost 4,000 participants, and requires 12,000 hours of staff. So it's very laborious and very intensive to work. Then on the other side, on the right here, we see the levels of evidence that currently have a high level. Although you probably should take into account that not all evidence will always get to the highest level, these numbers are still worrisome. Currently, research does not reach 25% of high-level evidence for most cardiovascular specialties. So here still we need a lot to work on. On the other side, of course, for more observational research, it's currently also a lot of work. Yet this research has less numbers as it isn't even practiced because of the costs. Then where do the major costs come from in research? And again, I take the example of clinical trials. The most costs come from recruitment and data collection. We see here a breakdown of the cost of clinical trial, of an average clinical trial on a person-per-person basis. There we see that administrative staff, medical staff, monitoring costs, and recruitment costs take up the biggest parts. All these cost parts could be made more efficient and probably cheaper when leveraging data from EMRs. So then, for the rest of this presentation, I would like to focus on the two parts just named: the eligibility, the screening of eligible patients, and the data collection from EMRs. On the left, again, we see the full pool of eligible patients that usually come into light for research. The eligible patient group currently has only to be screened by hand. By using EMRs, we can automate this process for a large part. Then on the right, we see how I view the EHR data against research data, again, trial data here. I believe that EHR data, by collecting it in routine clinical practice, has most of the data we have and we want to have for research already in it. There's just a small part that's probably missing and we still need to collect. This is an inherent mismatch between research and clinical practice and will probably never be solved or will be hard to solve. Yet if we only have to focus on a small part of research data that we need to collect, it would greatly increase the possibilities that we have for research. So then into the details. And here I've taken the TASTE trial executed in the Nordics of Europe. What the TASTE trial wanted to do was to see if thrombosuction in patients with myocardial infarctions helped, if it was actually beneficial as was thought. So what did they do? They included patients based on their on a very large registry, and the registry was based on EMR data. So it's a derivative of EMR data. Now, what do we see? We see that of all the PCIs, they could include more than half of all the patients who underwent that. Furthermore, we see in loss to follow-up that there was no loss to follow, not at all, which is extraordinary for a trial like this. How did they do that? Well, patients, it's less of a burden for patients and clinicians. Then to their results. Can it actually show results? Yes, it can. Based on the TASTE trial, multiple articles have been published in very impactful journals too. We see that they analyzed the number of reinfarctions and the number of stent thrombosis, and that these results were reliable. So see is in the next slide. And furthermore, they also did, the original study was 12 months. Afterwards, they did a legacy trial, which they could do because data collection was continued after the trial. And here we see a legacy study, or results of the legacy study after 3 years. Then does it have impact? Yes, it does. Before the TASTE trial, thrombosuction was on a rise. More and more clinicians were using thrombosuctions for their patients because it thought it was beneficial. Yet most of the data were, most of the research until then was based on observational studies. Then you see the TASTE trial coming into place. In the middle of the figure on the left. And the TASTE trial clearly showed that thrombosuction did not have a benefit, even could be a risk for patients. So afterwards, people stopped using thrombosuction and the number of thrombosuctions went down. So this trial based on EMR data huge consequences for clinical practice in this case. Then moreover, we see that they published multiple articles in the New England Journal, which of course is what we want. Yet, while we have seen that it's great that we can achieve great results from registries based on EMRs, there are also some challenges at this moment with results with registries. And these are mainly in the process, as registries are very laborious to make. We have a clinician who enters the data in the EMRs, does that as to the best of his abilities. But then we have to take the data from the EMRs and move them through to the registries, which is currently still a manual process mainly. Then secondly, most of the registries only include patients selectively. We have registries for heart failure, for myocardial infarction patients, for cardiothoracic patients. So we have a selective range of patients included in these registries. Then there's also an aspect of limited accessibility. These registries are mainly controlled by large organizations, which limit their accessibility. Furthermore, the inclusion of patients is generally either regional or national. In Holland, we're currently working on some very big national registries for cardiovascular patients, which is great, and we can do as the research we just saw. So hopefully we can have the same impact. Yet, if we want to do multinational studies, it limits us. And then lastly, we see that there are data limitations, because in registries, we predefine what data we want to collect. So if we miss any data, we can't do the research to answer our questions. Here on the right, you see just an example of one of the ESC registries and how much time it costs to build and how much planning go into, just to illustrate how hard it is to build these registries. So I'm a very big fan of using EHRs data directly from EHRs. Until now, that's only been done limitedly. And yes, we can. For Europe here, we see that most GPs and most hospitals already have EMRs in place. So we only need to mine them for their data. Then, moreover, the data in these EMRs is real-world data that's clinically relevant and written down by clinicians, used to guide their clinical decisions. And it's complete, so we're not missing anything. Then, as these EMRs are controlled by the GPs and the hospitals, they're also accessible on a per-site basis. So, and how would we do that? I don't think we need to use EMR data to replace our current research methods, data collection methods, at least not at this moment yet. For now, we need to have the EMR data supplement our research. We need to add a step where the text mining or the data mining of EMRs is used to supplement the data we regularly collect. And then we can still have the quality control steps in place to guarantee that the data is of the highest quality and the quality we want for research, because we don't want our research to be less accurate because the data wasn't correct. So in this way, we can make that happen by just supplementing. Maybe in a later stage, there would become a time where we can replace all our current data collection methods. But for now, just make them an intermediate step. And then how does that work? If we directly mine data from EMRs, can we actually do that? Me and my team researched this over the last couple of years, and I want to show you this in a bit more detail. For one big cardiovascular outcome trial, a recent one, we researched whether if we would have used patient EMRs to include patients, to screen patients for eligibility, would it have been possible to make a more efficient selection of the eligible patients? Then what we saw is that for this trial, all hospitals had to screen all patients who visited on their eligibility. So there was almost 100,000 patients in this case. Then when we put down our EMR screening process, the automated data mining screening process, we could automatically exclude 73,000 patients of that, so that the hospitals only would need to screen just 18,000, which is a fraction of what they originally needed. Then one of the things we unfortunately couldn't know is how many of these patients actually were eligible in the end. And that's because our study was retrospectively, so we couldn't see which patients actually were in the right bucket. What we could see, however, is that of the 568 patients eventually included, we caught 458, which is far the majority. Yes, we did miss some patients. So apparently there's a group that did not have the right criteria in their EMR for which we searched. That might be something of a flaw of our research or something that was in the EMRs. At this stage, we unfortunately don't know. Then what you see, if you look at the efficiency basically of the patients needed to screen to the patients included, we see that in an original situation that would be that we in generally include 0.6% of all patients screened. Well, in our new situation, we would have included 2.5%, which is of course a factor 4 more efficient. And then from the patients we screened, how much were categorized right and how much were categorized wrong. What we see here is on the horizontal axis, the data, the patients collected basically by the EMR methods. On the vertical axis, we see the use of conventional methods. And then I think these numbers are most interesting. The true positives and the false positives, basically. We see that our EMR gave a result of true, while in reality, in original trial being false in almost 10% of the cases. This is a problem with our algorithm. For the trial, if we would have done the manual screening step still, we could have filtered probably these people out, as we know what happened in their files if we would have spoken to them. On the other hand, we have the data which was labeled false by our EMR algorithm, but was true in actual data collection. This was 3.1% of the patients. This group is problematic still, as we wouldn't have caught them and thus wouldn't be aware of this group of people. In this, we want to research further in the future. Then on an individual level, how accurate are our events monitored? We see there that we almost make a sensitivity of between 80 and 100% different on the factors measured. On specificity, it's a bit the same. We see a large standard range, mainly in the outcomes that are softer to collect. So for instance, the mortality is kind of easily to measure as it's a binary variable. While on the other hand, the measuring of an ischemic stroke is harder, as people, as clinicians, put more text around. Then research to come. How does this relate on a time-by-time basis? What I show you here is currently one of our first results from a next study, in which we overlaid basically the results of our EMR research with the original trial results. And I'm not can't give you the zoom in here, but on a general basis, we can say that they're very closely aligned. More research on this to follow. Then what are the challenges still with data mining and data analytics in EMRs? I think they're basically fourfold. First, for every EMR, we currently have to develop a search group. So it's still laborious, and it's still a lot of work. Then second, the machine learning algorithms used are generally not visible. We don't understand them yet. So we need to find a way to make this more transparent and to see what happens behind it, mainly to analyze the 3.1% of patient miss. Third, we still have trouble with multiple languages. When I do my research in Dutch and I want to move my queries to English or to Spanish or Thai, for instance, that's very hard at this moment. We'd have to redevelop all the queries and are not sure whether the terms used in the queries are the same in a different language. And then fourth, we still need access to every single hospital. We don't have a centralized system, so you have to visit all the hospitals. Again, adding to the laboriousness of the research. So what we see then is that at this moment, on the left here is how the current system works. The data used from EMRs is basically used, is mainly the unstructured data, and the data is manually collected. I believe, however, that the top right quadrant of these 2x2s is the most relevant one, because in that quadrant we have the unstructured data, which is automatically mined. And I see that my vertical axis here is inverted, so excuse me for that. The top right quadrant should be the unstructured data quadrant, which is automatically mined. For this, we still need to improve our algorithm. But as clinicians mostly write down their notes in a text format, that's still the challenge we need to solve. This was my presentation. I'd like to sincerely thank you for your attention, and I hope we meet in the future.
Thanks, Mr. Van Djik. Now we'll go on to Professor Barbara Casadei, who will talk about the Euroheart study. Over to you, Barbara.
Thank you very much for giving me the opportunity to describe the ESC Euroheart project at this joint symposium of ESC and APSC, dedicated to digital cardiology and clinical research. So, first of all, what is it? What is Euroheart? And that is important to have very clear from the beginning, because Euroheart is a federation, an international collaboration that supports continuous online registration of high quality and harmonized patient data, and also provide real-time feedback, supporting therefore a continuous improvement of quality of care and outcome in patients with common cardiovascular diseases. In addition to that, Euroheart also provides an international infrastructure for cost-effective safety surveillance of new drugs and devices, and also registry-based randomized control trial in a general patient population, because these are the patients that come into the hospital and across multiple geographies. So it is quite important in terms of what it can achieve for patients with cardiovascular disease in one nation and in a federation of nations that would join such a project. And you would have seen the advantages of this system from what Singhealth has been able to achieve over the year using a similar system in just one nation. So why do we need it? We need it because we haven't conquered cardiovascular disease. Cardiovascular disease remains the #1 cause of death globally, and it's on the increase in developing countries. There are about 17.9 million patients dying of cardiovascular disease every year, and a proportion of them is also dying prematurely, in the order of millions. So we also see that common diseases remain common, unfortunately, and you can see it here. Ischemic heart disease, stroke are due to be at the top of the causes of death. These are European data, but it is even more obvious in other nations for years to come. And all of this is associated with a significant cost in terms of healthcare costs, productivity loss, and informal care loss, informal care costs. Again, these are European data, but they are generalizable. So in addition, we have wide variations in what is the age standardized death rate of cardiovascular disease in the world. These are the data from the global burden of disease. And you can see, therefore, that we need to understand what are the causes of these disparities, as well as find a way of improving the situation. And as Lord Kelvin said, if you cannot measure something, you certainly cannot improve it. And this is really the main remit of Euroheart. We do measure, and we do measure harmonized data that can be benchmarked and compared across the country. So, what do we have, therefore? What are the main components of Euroheart? Well, one is the common data set. So the countries that join Euroheart have an independent data collection that belongs to the country and stays in the country. However, they collect data in a way that has been agreed and harmonized in a community, and therefore in a community of countries, and therefore it can be easily benchmarked, and it can be easily used when one wants to, for instance, run a clinical studies, because we agree on the definitions. And in fact, we have now developed these definitions for a number of diseases. And you could see here the process. The process is to look at what has been done, summarize what has been done, and then collect input from registry leaders and expert groups on these variables, what it is that is really important to record for these patients now. And the process is then endorsed by the ESC Association and various national cardiac societies, a bit like the practice guideline, and then they're logged and published and reviewed and updated periodically. So far, this has been done for acute coronary syndrome and PCI, heart failure. Atrial fibrillation is getting to the last stage, and TAVI is under development. And all of this will form the basis of the data that are collected in a harmonized way by these registries. And you can see the methodology that has been published. So, to facilitate that kind of flexibility and also take into consideration the needs, the specific needs of individual countries, we have a level 1 mandatory variables that everybody will record. Then there is a level 2 additional variable that are optional, and there is also the possibility of having country-specific variable, and also to develop outcome modules, drug and device modules for observational study, and within a registry randomized control trial modules. So this is all part of the Euroheart structure. And you can see here some example of primary, secondary, level 1, level 2 variables, the numbers that have been developed for acute coronary syndrome, PCI, heart failure, and so on, just to give you the idea of what, how many variables are part of these registries. So then the Euroheart also provides optionally a platform, an IT platform that is based on the Sweetheart platform, in which to enter these data. And the platform is very well validated, and you can see here you can enter or you can capture medical data from your electronic health records, depending on how you're organized. And then there are result pages that on a daily basis give you a feedback on how you're doing, how many patients you've seen of this particular disease, and how well you've done, what is your time to needle, and etc., etc. So these are the countries that are under investigation, so far evaluation, I should say. We already have countries that belong to Euroheart, the Euroheart pilot phase. And they belong at 2 levels. Some countries, such as, for instance, Romania, has adopted both the variables and the platform. Some other country, like Portugal, have adopted the variable, but not the platform, because they have an existing platform, for instance. So there is flexibility, but there is still the potential, as I said, of benchmarking and doing then multi-center, multinational studies in this context, as well as the national. So, this is a very brief example of what we can get from it. These are an example from Sweetheart, and you can see that through this registry, they have been able to plot the mortality for STEMI patients over the year in hospital, 30 days, and year mortality. And you can see the trends, and you can see also that they have plateaued, so that this initial progress has really now not gone any further. So there is work to do here. And you can also see, importantly, and this is a map of Sweden, which are the countries that are doing remarkably well with very low mortality, and which are the countries that have higher mortality, the regions, sorry, that have higher mortality within a country. And then you can actually think of how you can make these purple areas like the pale yellow areas, and learn from each other. So this is a very important process. Similarly, one could look at safety of new devices. Here are plotted, for instance, the rate of stent thrombosis with a variety of stents, and that can give you an independent assessment. And also you could see that you can have a registry-based randomized trial. This is a classic, was the TASTE trial of thrombectomy that was run within Sweetheart. You can see long follow-up, very rapid recruitment, a negative results. But the equivalent commercial study here, the total, you could see that it had a shorter follow-up. It took much more to recruit and had to recruit a larger number of centers. The results was the same. The cost of the two was remarkably different. And so if we want to know more about the practice why we practice in a certain way. And, there are so many things that we know that are not exactly evidence-based. I mean, this is a way of finding out at a reasonable cost and within our structure in the patients that we see in our hospital. So very, very important point in my view. So in essence, Euroheart, we believe, is a good vision, is a great vision for the ESC, and really is completely aligned with the ESC mission. And we hope that other countries and affiliate countries and National Society, Cardiac Society of the European Society of Cardiology would be very much interested in this development. And here is the website, and you can learn more from this. Thank you very much for your attention.
Thanks, Barbara, for the very nice introduction to the Euroheart project. It's now my pleasure to invite my good friend, Dr. Alan Fong from the Sarawak General Hospital to give his talk on wearable devices in clinical cardiology research. Alan, look forward to hearing on your topic.
Good afternoon. My name is Dr. Alan Fong from Sarawak Heart Centre, Malaysia. And today, my lecture will be on wearable devices and clinical cardiology research. I have no conflicts of interest to declare. What is a wearable device? Wearable devices are commercially available health technologies such as smartphones and smartwatches, activity trackers, and e-health applications. The ESC's position paper published in March this year was a culmination of a working group looking at the use of commercially available wearable technology for heart rate and activity tracking in primary and secondary cardiovascular prevention. It explores opportunities and challenges to enable more rapid and effective implementation into clinical care. On this issue for advanced diagnostics and therefore intervention pathways, I will explore in my lecture the most critical condition of ST elevation MI, the most common arrhythmia, atrial fibrillation, and the most disabling condition, which is heart failure. The most critical clinical scenario in cardiovascular disease would be ST elevation myocardial infarction, or STEMI. And in the last 50 years, we have seen huge improvement in terms of inpatient mortality, moving from over 30% to less than 5%, with improved diagnostics and therapeutics to achieve better reperfusion of the infarct-related artery. All these are results of clinical trials, and in ST elevation MI or STEMI, one of the great gurus in this field had been Anthony Gerschlich, one of my mentors, who passed away sadly at the end of last year from complications of COVID. He was a primary mover for the publication in the bottom left-hand corner, which is the REACT study looking at rescue angioplasty after failed thrombolytic therapy for acute myocardial infarction. And it was the first clinical trial that I had participated in. I had the great privilege of working with him as country leader of the AEGIS 2 study, which is currently enrolling for improvement of cardiovascular outcomes. For ST elevation MI, data from REACT and other clinical trials have clearly identified areas that we could improve cardiovascular care and outcomes in STEMI, addressing patient delay, first medical contact to diagnosis, and reperfusion therapy. In the last set of guidelines from the ESC published in 2018, we have seen improvement addressing system delays and EMS delays to achieve reperfusion either by lytic therapy or primary PCI. However, we've only begun to make early improvements to address patient delay. And this is one of the potential applications for wearable devices. Early diagnosis leads to early treatment and better outcomes. At present, implantable sensors have already been in use to diagnose life-threatening arrhythmias. With the onset and the advent of wearable devices, we can soon be able to pick up such pathology, perhaps by looking at ECG patterns and ECG recognition in association with other clinical variables to pick up ST elevation MI. In addition, algorithms linking devices with smartphones, as well as in wearable vests, which can potentially deliver therapy, can improve early symptom recognition, call for help, EMS evaluation, and therapy. And in a context where time is myocardium, ST elevation MI management could yet revolutionize with wearable technology. And this is typical for many countries in the Asia-Pacific Society of Cardiology. Many of our member countries have subjects and patients who live very far from tertiary referral areas, such as where I live, and the Sarawak Center is the only public access tertiary referral center at only the southwestern coast of the entire East Malaysian state of Sarawak. The next area for my discussion will be atrial fibrillation. Atrial fibrillation definition at present, which is a period of AF of the duration of at least 30 seconds duration. And this changes the management by which anticoagulation therapy is applied to prevent or reduce the risk of thromboembolic events such as stroke. Atrial fibrillation in terms of burden of disease compared to North America, Asia is stunning. Already in men, in a few years' time, it is projected that the number of patients with atrial fibrillation will be approximately 5 times in Asia that of North America, and this is similar to that in women. So guidelines again have been published, and here in 2020 showing patients with atrial fibrillation clinically risk stratified, in such as a risk scoring such as a CHADS-VASc score, recommends the use of oral anticoagulation such as a NOAC in patients with non-valvular atrial fibrillation to prevent stroke and cardiovascular events. In addition, for symptom control and also other clinical syndromes associated with atrial fibrillation, rate and rhythm control strategies have also been outlined. In addition, atrial fibrillation still maintains a risk for stroke, and anticoagulation still mandated. Therefore, screening of atrial fibrillation becomes important, and there are many ways now in terms of the ability to doing so with the onset and availability of wearable devices, both in terms of what can be commercially available and those that are implantable. However, it is also useful to note that most of these technologies are now available in clinical practice. Using the smartwatch to detect atrial fibrillation has been the flavor of many industry in the last few years, and these are 2 publications in 2019 looking at the smartwatch from the Apple as well as from Huawei, looking to detect atrial fibrillation by using their proprietary watches as well as algorithms. Wearables to define atrial fibrillation and its management will change in the near future with the availability of patch monitors, on-demand variables such as the AliveCoreCardia, and such technologies that combine other sensors such as physiological parameters as well as blood parameters. And in the future, such technologies would enable both the patient and the clinician to provide more precision-based care for the management and diagnosis of atrial fibrillation. In our publication this year, we looked at detecting atrial fibrillation in patients admitted with cryptogenic stroke or TIA with sinus rhythm. And at present, in patients conventionally with sinus rhythm, patients are discharged on antiplatelet therapy. However, using a new algorithm, such as in our case, the AliveCoreCardia protocol, we were able to detect more atrial fibrillation patients with atrial fibrillation compared to that with conventional 24-hour Holter. And this had changed the management because the patients were prescribed anticoagulation rather than antiplatelet therapy alone. Beyond the technologies such as the Alive Cocardia, we also report contact-free atrial fibrillation detection by smartphone. And this is work done by our friends in Hong Kong, Professor Brian Yan's group, looking at initial work using a smartphone for facial pulsatile plethysmographic signals to detect atrial fibrillation, and subsequently developing the technology to be applied in a more large-scale basis using high throughput work with video with deep learning. So finally, looking at the most disabling condition, heart failure. Heart failure is a disease that is much associated with both mortality and morbidity. So technology to monitor for subclinical deterioration and the management of stable chronic disease, as well as detection of acute heart failure, becomes important. Many of these patients also have comorbidities such as diabetes, hypertension, and indeed atrial fibrillation. So the potential for the use of wearable devices to improve the outcomes of patients with heart failure becomes important. And these are all areas for potential clinical research, such as opportunities to improve care. At present, in a patient like this, with heart failure, with a broad QRS complex, and poor left ventricular ejection fraction, both therapeutic as well as diagnostic monitoring enshrined in this CRTD type technology system, hereby implanted by my colleague Dr. Koh at Cerebral Heart Center. So in this situation, both the diagnostics and therapeutic care are delivered through the CRTD system, and including opportunity for measuring pulmonary congestion in this particular system. However, the wearables and the potential for use in heart failure extend beyond just electrical monitoring, but also measurement of vital signs, surface of sweat markers, blood markers, cardiac rhythm, and also other physiological markers which can be incorporated into such technology. So from heart failure to post-MI rehab, all these areas are potential work for cardiovascular clinical research. And this was addressed also by our co-chair, Professor Khung Keong Yeo, at this year's EuroPrevent 2021 conference in April. So therefore, we can see that early diagnosis does save lives and save resources, for early diagnosis also empowers patients with cardiovascular disease. So cardiac conditions, because they have quick and very steep tipping points, require better diagnostics, any better from wearable technology at home. Even though centers may be heavily subsidized for first-class care, such as in many developing countries, in urban centers, they still have to get there if the patient deteriorates in rural area settings. In-depth research for more targeted care, for example, including molecular diagnostics, will be important to complement what can be done together with wearable technology, and obviously opportunity for multidisciplinary and integrated care. So the 21st century patient in the APSC sphere who will most likely use or have a wearable. These patients now have longer lifespan, and in this area, cultural challenges as well as rural-urban migration have seen more adaptation of wearable technology, especially highlighted during this COVID-19 pandemic. The emergence of IT expertise for wearables, for example, in healthcare setting, will see increasing applications and manufacturing for such ecosystem. And the use of wearables and clinical research for cardiovascular care will certainly allow us to redefine disease, ID protocols, and care pathways. Finally, because of the way this has moved on, a global standard will eventually be required. And we are very glad to see the ESC taking a very much proactive approach, publishing this position paper earlier this year. So in a global, connected, heart-conscious world, we have also participated as a team into the ESC Digital Summit in 2019. This was the inaugural conference looking at digital healthcare for cardiovascular ecosystem. And our team were very happy to present some of our data there. And I invite you to attend this year's ESC Digital Summit, which is a virtual event next month. Finally, for wearables in cardiovascular clinical research, diagnostics and therapeutics, and Malaysia no different. And our 5G deployment awarded to Ericsson in a very large multi-billion ringgit project to improve both access as well as applications for both communications and healthcare. Computer processing powers improved tremendously, and including even the size of a chip, so much more can be done. So much so that they can implement technology into therapeutics such as this handheld defibrillator, so that we can have more time eventually for empathy and compassion towards the management of our patients with cardiovascular disease. And with that, I thank you very much.
Thanks very much, Alan. So it's unfortunate that Mr. Van Djik and Barbara can't join us today. So, I'm actually going to get going with some of the questions because, I think as we heard from, Wouter and Barbara, there's much to talk about. So I want to ask you, Alan, what do you know of the penetration of electronic health records in this part of the world, in the Asia Pacific? How is it in Malaysia?
I think electronic health record penetration in many of the developing countries like Malaysia is still at its infancy. We do not yet have an integrated national level database that is real time so that it can address disease conditions, including non-communicable diseases, in a rapid manner. Of course, in the context of the COVID situation, it is shown how important real-time data is in terms of how we design interventions to improve outcomes. So for most of these countries, I think opportunity to invest and to a policy that guides better use of data collected and implemented. Thank you.
Yeah, so Alan, in Singapore, we have, pretty much all the public hospitals have electronic health records. But these, in order for them to be enterprise grade with the appropriate cybersecurity, we were subject to a massive cyber attack in 2018. All these things require a lot of money and a lot of training. So I see two big problems with electronic health records in our region. Number one, the major players globally are expensive. Whether you talk about Sunrise or Epic, they do cost a pretty penny, and it might be prohibitive for many of our regional many countries in this part of the world. The second is that the language that is used can vary tremendously, whether it is English or in Malay, the Malay language, Mandarin or Chinese or the Philippine dialects. I think having different languages and therefore the coding and all its attendant challenges will be a major issue. So I think where Mr. Van Djik illustrated the vision and the dream of having electronic health records facilitate research, it will be a while further in this part of the world. I think it is doable, but it is not an easy problem to surmount. I also have a bit of slightly a bit more questions on electronic health records. Maybe just to ask Alan, in terms of harmonization, do you in your research projects use harmonized or data standards like OMOP or other data standards in the way you record data and and do this type of retrospective research?
No, I don't think we're at that kind of level of complexity as yet. But I do share your optimism. And having worked with you at the APSC over the many years, and as our chair of the Scientific Advisory Board, I think I would like to make comment on two of the things that you raised. First, the cost of such systems. Yes, it is going to be prohibitive and probably out of reach for most of the healthcare providers in our 21 member countries. On the other hand, I think one option beyond or besides using a national level kind of situation is to look at institution perspective. So there may be some institutions who will be keen to participate in a closed net type registry system where you get standard variables being collected. And I think your initiatives, particularly in some areas of disease, cardiovascular disease such as STEMI, has already seen some positive moves, such as the ASPECT registry and the kind of work that's being done there. So I think to limit or to mitigate the costs, perhaps eventually from a unified APSC perspective, not only at a national perspective, but at institution per institution collaboration could provide the first early steps. On the second aspect, in terms of language and harmonization, I think the advancement for language type switching and programs now are quite tremendous. I think many even of the social messaging apps, you could type in one language and the message is delivered in another language. I think those can be surmounted in time with the AI moving forward, during translation. But I think the key part of what you have mentioned is correct. For EMR, the key items that Wouter had brought up was the actual diagnosis. The variables have to be unified. So I think if we get the simple variables that has to be the same, I think we can go a long way to harness the strength of the APSC, and we look forward to that in the coming years.
Yeah, thanks, Alan. In fact, that's what we hope to do. It's not just within APSC, but as you mentioned, the ASPECT group, working with yourself, with the rest of us in APSC, I think that's really made some progress in terms of MI outcomes and procedural outcomes, and we have started to work to get some ways in terms of harmonization of the data variables, the data definition, so that data from one country can be understood in another country, and as a whole, the Asia Pacific can have sort of a coherent data presentation. Now, along those lines, right? I want to ask, do you think that how do you think and why do you think countries need to have registries? I mean, the Euroheart is a great initiative, but registries are double-edged swords. Do you see a need for registries in the Asia Pacific, and why?
I think it's fundamental work for all clinicians to try and improve the healthcare status of their patient. And from the healthcare provider setting, I think the registry is also very important, extending from the individual to health systems and populations. So as we know, primary PCI is the gold standard for the management of ST elevation MI, but it's only accessible to only a small proportion of the APSC population. Out of perhaps 700 million here, perhaps catchment area, maybe only about 10% who qualify to meet those guidelines. So beyond that, and how do we manage ST elevation MI and yet improve the outcomes, we may well need to have some kind of registry. In some areas, perhaps there could be a factor by which we do not need to intervene because it will not make a difference to the outcome. And on the other hand, not every primary PCI patients demonstrate 100% LV recovery at follow-up. So to be able to discern this kind of aspects, to tease beyond what is relevant to what is supposed to be the gold standard, the registry model is very important. I think it gives us a reflection of how patients are managed in our region, because ultimately we want to generate the kind of data that shows improvement in outcomes, particularly in the APSC. I think it is very useful to have registries to compare not only the healthcare intervention strategies, but also in terms of policy. Because not every country at the APSC member country has actually universal health insurance coverage.
Yep, I think you hit upon a few key points, and just to share, maybe just to emphasize them. I think registries in well-characterized disease processes or processes of care are crucial to help us improve the delivery of our care. And we have learned from the Americans, the Europeans, and also from our own experience that when we started measuring STEMI outcomes, when we started looking at door-to-balloon times, and when we started to see where we can shave off precious minutes, it ultimately led to superior process of care and superior patient outcomes. So it's no point telling ourselves we are doing such a great job when we have nothing to be able to measure and there's no mechanism for learning. So I think registries are crucial. I think the other way where registries can help is if they help pick up problems that we have not previously known. For example, if you have a registry on, say, a new therapy such as, say, the mitral clip, and you think that you're doing such a great job, and then when you look at the registry, you realize that, hey, perhaps some patients are not getting certain types of treatment. Maybe they're not getting guideline-directed therapy, or maybe not enough patients are being referred. But regardless, it does offer opportunities for picking up problems that you otherwise have no way of knowing. So I do think that where possible, within the APSC, we should work closely together to define types of diseases, types of processes where we should actively measure and collect data on. Having said that, I don't think we can boil the ocean. I think we need to start in very well described cohorts where there is, how do I put it, a lot of room for individual countries to improve on. So I think there'll be an ongoing conversation with our stakeholders, with each country, to see what is important to them as a group, and then we can take that next step. With registries, one question, Ellen, I have for you is that you contribute to the audit to the aspect registry, but the question I have for you is, do you think audit is necessary for registries? I mean, people. I remember once I heard a presentation in which the registry had 100% survival rate, over a 10-year period, and I said to myself, wow, that is a very powerful registry. But I mean, I'm joking, of course, but I don't believe any treatment where mortality is an event can have 100% survival. Where do you think, and how do you think we should do audits in such an environment?
Yeah, I think fundamentally the audit situation is critical to maintain the data quality, and therefore the registry data makes sense. In Malaysia, for our National Cardiovascular Disease Registry, there are some variables that have to be assessed by the National Heart Association Malaysia to ensure that these variables actually fit and match up with the source document for at least minimum data quality. So I think any registry worth its salt should be able to open their books to ensure that what they are reporting is actually what actually happens. Otherwise, it's not going to be applicable or what it reflects in terms of the message or the result that it produces. So I agree with you on that.
Yeah, I think that's going to be crucial as we journey on this together. It will take some time. I think if we start off right away and we incorporate an audit right away, it will be very difficult because it's time intensive. It's also rather painful in terms of clearing governance, but I think we need to get there eventually. Now, Ellen, I was very impressed with your study, your group study on the AFib detection in stroke patients using the AliveCore device. I have two questions, and this is actually quite a difficult question, so you pardon me, and that is, did your research result in a change in clinical practice? And if so, how did you implement it in workflow? And if no, why not?
Okay, I think the easy answer to the first question is yes, because we moved from doing routine Holter to using another technology to assess patients with a cerebral vascular event admitted with sinus rhythm. So that is the first point. And it changed clinical practice in a way that it has encouraged us to move to another technology. Because in our setting, the funding at the moment is still directed at research for this arena. So we're moved to a secondary project now, looking in the same group of patients using a different technology to pick up atrial fibrillation in patients admitted initially with sinus rhythm having a cerebrovascular event. The reason why it had not been translated fully into clinical practice in a public healthcare setting is solely down to cost at the moment. So there's still health economic analysis being made. And there is still a challenge in terms of how do we model this to make sure it gets a fair crack of the whip. Partly because there is very little in terms of how we manage a cost at micro-costing level in a heavily subsidized system such as Malaysia. I think if you apply a costing model, for example, in a developed country, for example, like Singapore or Hong Kong, I'm sure you'll find it a very cost-effective measure to use a live core cardiac system in such group of patients.
Yeah, I think that's really one of the biggest challenges, and that is not well addressed when we talk about digital technologies and wearables. And that is the question of implementation data science and cost effectiveness or value to the healthcare ecosystem, including the patient's pocket. So in your example of the Alive Core, that technology has been around for some time. It's not terribly difficult to use. But when we deploy this, the question is, how much would it cost right from the get-go? What is the purchase price of these devices? Two is, can we convince patients to use it regularly? And three, if that is not done regularly, what is the downstream effect and cost and wasted opportunity, so to speak? And thirdly, what kind of backup measures do we do should something abnormal be picked up? Do we need to have, a battalion of nurses or technicians or doctors on standby? I should say something worse than an atrial fibrillation is detected, heart block, VT or whatnot, And if, let's say, no one is available to answer those phone calls, what are the consequences for the healthcare system? So unfortunately, none of these answers are straightforward. And I would say that, within Singapore, as you say, somewhat developed country, we are terribly mindful of this. And whenever we have the new tech, we ask those difficult questions. Is it cost effective? Does it change workflow? How do we implement this? Can we derive value from it over a period of time? So I think this session has been critical or very useful in articulating and allowing us to share a little bit of what is possible in the digital arena, in data science arena, and what the challenges might be. So I'll just perhaps summarize some of the key points. I think we heard from Mr. Van Djik that using electronic health records is a great way for doing clinical research. It is possible, but I think as through our discussion, a lot needs to be done before it becomes mainstream in our practice in this part of the world. We have heard from Barbara Casadei, the Euroheart study. I think that is a very ambitious project that we can do well to partner with, but there's a lot more that we can do at home in terms of our own healthcare systems and registries. I suggest that within the APSC, we work on a few key areas to harmonize data and to get some stuff going. And lastly, Alan, you spoke about wearables, and I think the work that you do is tremendously impressive. However, there's a lot more that remains to be done, and hopefully at next year's APSC, we can hear more on where you are in your journey. So with that, I'd like to thank all our speakers and look forward to having you join us for the rest of APSC 2021. Have a good day, everyone. Thank you.
Thank you very much.
Thank you.